Hello and welcome to another episode of Cracking Addiction. My name is Thaleep Naren and I'm joined as always by Dr. Fergal Armstrong. In the episode today, we're going to follow on from our earlier episode when we talked about opioid use disorder in pregnancy, and we're now going to talk about the post-delivery period. So Fergal, what are the main things we need to consider in a woman with opioid use disorder who's just delivered her child?
So I think there are three main issues we need to consider. Firstly, the health of mum, the issues around breastfeeding, and then thirdly, the health of the baby. So if we start thinking firstly about the health of mum, it's not so much an issue with buprenorphine, but when we're thinking about mums who have delivered and they're on methadone, remember I said in the earlier episode that the placenta actually has a lot of CYP3A4 in it. And so the placenta contributes to the overall metabolism of methadone in pregnancy. And that may actually necessitate an increasing dose in pregnancy. Now, when mums deliver, remember they lose the placenta, they also lose baby, and they also lose a lot of body fluid. So there's a significant change in the body composition of mums. And so those two factors may then contribute to an elevation in the plasma concentration of methadone, which may then cause mum to feel drowsy. So immediately after delivery, and really also for a period up to 12 weeks after delivery, there are changes in the body composition of mum, the fluid balances of mum, which basically means that for the same level of methadone, you may be experiencing different plasma concentrations. And we need to be mindful of that. So I think really it behoves mums to be carefully monitored, certainly daily in the first 3 or 4 days, and then definitely weekly for at least the next 12 weeks. Because with this elevation in plasma methadone concentration, mum may become drowsy, and so we need to be looking out for that. There are various ways of managing the potential risk for drowsiness in mums after delivery, and I've seen all three methods work. So I've seen mums just stay on the same dose of methadone. I've seen mums reduce their methadone dose a little bit, and I've seen mums reduce their dose by 50% immediately after delivery. And then over time, the dose of methadone is then recalibrated to mum's requirements over the next 12 weeks. So I'm not saying there's a specific right or wrong answer, but I am saying that every clinician who's involved in the care of mum after delivery who's on methadone, they need to be aware of the potential risk for sedation and drowsiness, and that needs to be managed, especially if you're giving mum's medication for ongoing pain relief. So if mum's had a cesarean section, which is very painful, remember, you then need to start thinking about whether or not you're going to give opioids to an opioid-dependent patient who's got fluid balance shifts and loss of 3A4 and is already on methadone. So I think the key is careful monitoring.
Thanks for that great summary, Fergal. And it's something that we as prescribers really need to be vigilant about, especially in the postpartum period for a woman who was on a sufficient dose of methadone to manage her pregnancy. But with all the fluid shifts and the loss of the placenta, that same dose of methadone may be toxic to her in the postpartum period and could cause respiratory depression and death. Is that fair?
That's fair enough. And the key to managing it is to closely observe mum.
So this brings me to the second topic that you were talking about, which is breastfeeding in the post-birth period. And a lot of women are very concerned about breastfeeding while being on methadone and Suboxone and worried about harming their child. What would you say with regards to breastfeeding while on opioid substitution therapy, Fergal?
So I think the overall point to get across is that opioid replacement therapy does not contraindicate breastfeeding. And actually, we should be encouraging breastfeeding, especially in mums with opioid use disorder on ORT, for the sake of baby. But if we look at the kinetics, we're looking at methadone. So we know that methadone in breast milk, there's about a 1 to 3% of the dose transferred. So if someone's on 100 milligrams of methadone a day, you're looking at a 1 to 3% of that going into breast milk. So really, we're looking at very low doses of methadone in breast milk. And actually, we also know that if we're dealing with neonatal abstinence syndrome in mums who have had methadone and are still taking methadone, actually that, even though they're breastfeeding their child with and they're taking methadone, that's not enough actually to treat the neonatal abstinence syndrome. So there's two pieces of evidence to suggest that really the effect of methadone in breast milk is trivial. Then if we look at buprenorphine, well, we know that the transfer into breast milk for buprenorphine is less than 1%. But we also know that buprenorphine is only absorbed sublingually. So even if baby swallows less than 1% of the maternal dose, it shouldn't actually get into the systemic circulation of baby because the baby's swallowing it. So again, the risks to baby from maternal buprenorphine, again, are very trivial. So for those reasons, and for various other reasons associated with the benefits of bonding, et cetera, I think it's important for all clinicians to encourage breastfeeding.
I think that's so important, and that's exactly the advice that I give my patients as well. And going on to neonatal abstinence syndrome, it's a topic that I think we touched on briefly on an earlier episode, but something we should talk in a bit more detail about now because it is a significant concern for mothers in particular. And one of the reasons why a lot of women consider stopping opioid substitution therapy. So neonatal abstinence syndrome is when the infant is withdrawing of the substances they've been exposed to in utero. What's your spiel that you give women with regards to neonatal abstinence syndrome, Fergal?
Well, firstly, we need to understand that neonatal abstinence syndrome, NAS, doesn't just occur with maternal exposure to opioids. It can occur with maternal exposure to many other drugs, including antidepressants. Secondly, the risks of neonatal abstinence, certainly with opioid replacement therapy, are not dose dependent. So lowering the dose of any opioid replacement therapy during pregnancy is not going to reduce the child's risk of developing NAS. Whilst there is a higher risk for babies of developing neonatal abstinence syndrome with methadone than buprenorphine, the risks of withdrawal in pregnancy are greater than the risks of neonatal abstinence syndrome after delivery. At the end of the day, neonatal abstinence syndrome is a treatable condition, whereas withdrawal in pregnancy can actually cause a miscarriage. Neonatal abstinence syndrome is you potentially need to observe babies for up to a month because you can get a delayed presentation, but the commonest time to present is up to the first 5 days of delivery. And so there are particular scales that we can use. And one commonly used scale that is used to identify neonatal abstinence syndrome is the Finnegan scale, or the modified Finnegan scale. And that looks at a wide range of physiological and behavioral parameters. Which I can't remember specifically the parameters, but I just think of it as gastrointestinal parameters, neurological parameters, cardiorespiratory and metabolic parameters. And really what you're looking for is a sign of baby's distress. And really, it's poor feeding, vomiting, jitteriness, crying a lot, not being able to be soothed. And also, really, there is a small risk of seizures. But the bottom line point to make is that the risk of neonatal abstinence syndrome to baby is less than the risk of withdrawal during pregnancy. And so lowering the dose and not treating opioid use disorder in pregnancy is a more harmful intervention.
Absolutely, Fergal. And the thing I often tell women is the treatment for neonatal abstinence syndrome, first line treatment, is usually symptomatic management. What we do is we nurse the child in a quiet room, in a darkened room, we swaddle the child, and we provide symptomatic management. So there's no real medications used as first-line intervention most of the time in neonatal abstinence syndrome. And depending on the scoring of the modified Finnegan scale, if the score is quite significant, obviously we do use medication, and a lot of the time a bit of morphine may be used based on the scoring. But a lot of the time with neonatal abstinence syndrome, basic symptomatic management, reassuring the child, contact with mother, holding the child, breastfeeding is a lot of the first line management of neonatal abstinence syndrome. So it is a condition, as you mentioned, that is well known. easily identified, and very easily treatable.
Yeah, yeah. And really that feeds back to, the fact that breastfeeding is so important. And really breastfeeding and the delivery of methadone via breast milk hasn't actually been shown to improve the outcomes of NAS, but breastfeeding per se has been shown to improve outcomes in NAS.
In the episode today, we've talked about the monitoring required in the post-birth period for women on opioid substitution therapy, the importance of breastfeeding for women who are on opioid substitution therapy and how it is safe, and also about neonatal abstinence syndrome, how to identify it, how to monitor it, and how to treat it. So thank you once again for your company on this episode of Cracking Addiction, and bye for now.